Our topic for today's webinar is Older Adult Behavioral Health, Evidence-Based Interventions and Sustainability. This webinar is designed to provide you with training as health center professionals to learn more about adult behavioral health and the evidence-based interventions available and sustainability strategies. You are going to learn about issues related to older adult behavioral health, how common mental health and or substance abuse disorders are among adults over the age of 65. You're going to learn about depression and other behavioral health disorders which are not a normal part of aging, and evidence-based programs are available and how to link your clients in the community to these programs. And then you will also learn about strategies to sustain the behavioral health interventions for older adults. So without further ado, Ms. Emily Watson, we would like to introduce you to provide today's training, and thank you again for facilitating this discussion.
My contact information is available here, and I'll also have it at the end. It's my first and last name, emily.watson@ncoa.org, and that's my telephone number. 15% of residents of public housing are seniors, and the behavioral health challenges they experience face a number of challenges, including stigma, not wanting to bring up any sort of depression or mental health and or substance misuse they're facing. First, a little bit about NCOA and who we are. Our website is ncoa.org, and we are a nonprofit service and advocacy organization based in Washington, and our mission is to improve the lives of millions of older adults, especially those who are vulnerable and disadvantaged. And how do we do this? We accomplish our mission through four strategic visions, one being collaborative leadership. We bring together all sectors, private, nonprofit, and public, to address key challenges of older adults and of an aging society. We really pride ourselves on innovation and help develop and bring to scale innovative services that improve health and financial stability. We are the leading national voice and advocate for vulnerable and disadvantaged older adults and the organizations that serve and help these older adults. And we work with thousands of organizations across the country to help seniors find jobs and public benefits and improve their health and live independently. Our goals for 2020 are to improve the health of 4 million older adults, particularly those with multiple health conditions. And we will achieve this through participation in evidence-based health programs that we know to be cost-effective and have a return on investment, as well as very significant health outcomes. Our other goal is to make self-care an integral part of overall health care in the United States for people with multiple chronic conditions. And self-care here is inclusive of both the chronic disease self-management program and that model, as well as depression care management programs that I'll talk about in just a minute. Fully 1 in 4 people over age 55 experiences a mental health disorder that is not part of the normal aging process. That includes anxiety, depression, mood disorders, and cognitive impairments. And the largest challenge of those is depression. Nearly 1/5 of older adults experience symptoms of depression. So as you can see, that's a large percentage, and the good news is that treatment works. And what are the evidence-based interventions that are available? There are 2 depression care management programs that the Administration on Aging, the agency within HHS that is focused on aging in older adults. Healthy Ideas and Pearls are the name of these programs. And I put the links up here because in this short webinar, I won't have time to go in to detail on either, but I encourage everyone to look into them. They both use a in-home care management model. So this has been very successful in some community health centers partnering with aging service providers like area agencies on aging. And there's exciting work going on with health reform and the accountable care organizations with new risk-sharing entities. So care management this is considered an enhancement of traditional in-home care management. Healthy Ideas is embedded into regular case management. It uses licensed mental health providers, and it lasts about 3 to 6 months, and it incorporates both in-home visits and telephonic visits. And the primary difference between Healthy Ideas and PEARLS is that PEARLS also has a psychiatrist oversee and provide specific recommendations for patients, including and treatment for patients, including medication recommendations and that type of thing. But both utilize care management services that are ongoing and provides this as an enhancement of types. And the PEARLS program uses problem-solving therapy with 8 sessions at home over a 19-week period, and the Healthy Ideas program uses behavior activation over, like I said, the 3 to 6 month period. So I'm going to mention, and under screening, brief intervention, and referral to treatment, SBIRT, and information on this is available both on the SAMHSA website, or you could email me to follow up. But the screening, brief intervention, and referral to treatment SBIRT model is a very popular model, and it uses the principles of brief interventions and pre-screening screens and referrals to treatment to utilize. It can be pretty low lay leader, low staff persons to do, particularly the pre-screen and the screen, and then different levels of medical staff can be trained to do the brief intervention, which is about a 20 to 40 minute, depending upon the model, intervention that looks at the alcohol or medication or substance use that an older adult or any adult is using, and gives them a workbook to work, and you work through with them during the session, during the brief intervention, what their level is compared to recommended levels and steps they can take to make healthy choices and to make sure that their alcohol or substance use is safe and healthy. And then depending upon the level of potential misuse, referral to treatment is a very important piece. So the warm handoff to the substance abuse or mental health provider. And that's something that I worked on in the last year and a half on translating this to include psychoactive meds, knowing that that's a real challenge with older adults with the opioids and the pain and sleep medication. And it's a really, really strong model, and the evidence is very strong behind that. They've been doing that since about the 80s from the University of Michigan. So I'm going to mention some resources that are available on the SAMHSA website, and your FQHC or any other community organization is can order these toolkits for free. And one is the Suicide Prevention Toolkit, which is specifically for a toolkit for senior living communities, but it has the information that's applicable to everyone, and it's about promoting mental health and preventing suicide among older adults, and some of the best practices that, as community organizations, people may not have that specific specialty, so it's a really great resource. There's also an upcoming depression and older adults toolkit, which I believe is already on the SAMHSA website, but the hard copy will be available to order soon. And I'm going to talk about the Get Connected Toolkit, which is also, all of these are available on the SAMHSA website, and you can go to store.samhsa.gov or type into the search bar in SAMHSA for any of these resources. So the Get Connected Toolkit was put together several years ago, and it's about linking older adults with medication, alcohol, and mental health resources. I would really encourage anyone on the line to order this toolkit. It's a fabulous resource, and it was designed to advance substance abuse prevention messages through educating both the providers, so both the community health staff in this case, as well as consumers. And there's two pieces in the toolkit, one for providers and one for consumers. It also provides screening and referral tools for the misuse of alcohol and medications and mental health problems for older adults. And it helps community-based entities like aging service providers as well as FQHCs provide support to build promotion messages, offer education and messaging, and provide those tools for misuse of alcohol and medications. And it focuses on three things: coping, to better cope with issues related to medication, alcohol, and mental health issues among older adults. The second focus is coordinate efforts in a community to address these issues, and link. The third emphasis is link organizations and older adults to community-based and national resources. So it's about knowing what's going on in the community and knowing where to point folks to, and not being afraid to address some of these issues. And some prevalence and stats on substance misuse in older adults is that almost 20% of older adults misuse medications and alcohol, and that's often unintentionally. And as I mentioned, about 25% of people experience mental health problems that are not part of normal aging. So collectively, it's about a fifth and a quarter. And the toolkit helps emphasize that the quality of life can be improved and prevention works. And these are two of the most important take-homes on this issue, is that these aren't unconquerable issues. These aren't issues that we can't do anything about. So this is what the toolkit includes. It includes the program coordinator's guide, and for the support materials, it includes fact sheets and handouts, forms and resources, and the education curriculum. And in addition to providing the public education and consumer education, it helps staff and older adults understand substance abuse and mental health issues in this population. It increases staff confidence to address these issues. It provides tools and resources to educate older adults and link older adults to resources. So it's a fabulous resource that's available for free for your organization to order a hard copy. You can also download the HTML PDF, but it's nice sometimes to have the hard copy, especially to run off copies of the consumer materials. So we thought this audience would be a great time to talk about how FQHCs can partner with the Aging Network and who the Aging Network is. So for some background, the Older Americans Act was passed in 1965 in response to a concern about the lack of community social services for older persons. And this was also in the same bulk of legislation that passed Medicare and Social Security in the mid-60s. The Act also created the Aging Network to provide services to community-dwelling older adults and established the Administration on Aging, AOA, as the federal agency focused on older persons. And the makeup of the Aging Services Network is a group of agencies at the local, area, and state level that deliver social, health, and nutrition services for older adults through 56 state agencies on aging, 629 area agencies on aging, also known as AAAs, who contract and work with over 20,000 service providers and an additional 44 tribal organizations. And these community-based organizations serve as the bridge between clinical treatment and home. So now I'm going to talk about a report that Dr. Webb mentioned at the beginning. It came out last year, and it was a project that myself and my colleague Alex McNeil did in collaboration and for SAMHSA. And this is lessons learned on sustainability of older adult community behavioral health services. And what we did in this study was we looked at past SAMHSA grantees. And SAMHSA, if anyone's not familiar, is the Substance Abuse Mental Health Services Administration within HHS, as well as past CDC and NCOA grantees who had been funded specifically to do some sort of behavioral health intervention. And these were fairly significant grants, 3 to 4 years, at an average of about $250,000 per year to community organizations, 2 of which were FQHCs. And we wanted to know who sustained 4 to 6 years on. These were people whose grant period had ended in the mid-2000s, and what lessons we could learn from those who fully sustained, from those who partially sustained, and those who did not sustain. So the first step we did in this project was to develop a sustainability framework. And we identified this from the literature. We looked at about 30 studies of social services and health programs that were that had previously looked at sustainability literature. So I'll talk a little bit more about the sustainability framework, but that is one of the key resources that's available in the Lessons Learned report. And it's we got great feedback from those that we interviewed, including the FQHCs, about the language being very helpful and it being a very good framework to think about sustaining services in the long term. We convened an expert panel to review findings and inform recommendations, and we published the report. So that's available on the National Council on Aging website, NCOA.org, and I'll talk a little bit more about what we found. And this is just my favorite cartoon to really summarize what we know about sustainability. And it's one dinosaur saying, "All I'm saying is that now is the time to develop the technology to deflect an asteroid." So we all know that planning early is essential, and it really means from day one. So the definition we adopted of sustainability is the extent to which an evidence-based intervention can deliver its intended benefits over an extended period of time after external support from donor agency is terminated. And we use 3 measures to define sustainability. The first being continued program activities, continued measured benefits or outcomes for new clients, and maintain community support. And we looked at it in 3 ways. If the programs continue, if there were 5 components of the new behavioral health initiative, if 3 were continuing, we would call that partial continuation. Or if all 5 were continuing, but at a significantly decreased level, reaching maybe a quarter of the older adults or adult population that was receiving services during the grant, we call that partially sustained. Fully sustained was about commensurate with what was the level of service that was being provided under the grant, and not sustained was none or virtually none of the services from the grant continued. And we learned perhaps more from those who partially sustained and those who did not sustain about what's absolutely essential to sustaining behavioral health services. And I'll also mention that we looked at behavioral health services, but this can be applied to any health services at all. So the sustainability framework came up with 17 factors, and they were categorized into 3 groups: programs, inherent, factors related to the program itself that was selected, the organization that is implementing the program, and the community in which that organization lives. So some factors were found to be more important, but no factors were found to be unimportant. And we developed that model of program, organization, and community from this Israeli article in 2008. So the program factors, and I'll just pull out a couple. Demonstrated effectiveness is both, and it's not just that the intervention is evidence-based. That's, of course, important, but it's very important that you are able to demonstrate that your health center is getting the same outcomes. So continual program evaluation is really essential. And 3, I'll just pull out that one, fit with the organization mission. It's essential that this is in line with your overall organization's mission, and that behavioral health is an important function of the health services that your agency is delivering. And this framework is ranked within each of the factors. So not to say, obviously, that human resources is not important, but when it comes specifically to the issue of sustainability, these things were found were the former grantees felt that those ranked above were more essential to sustainability. But like I said, all 8 are very, very important. And the third group is community factors. So the availability of resources, that the community believes the service or program is important, and that there are functions that allow the service to thrive. So of the 12 former grantees we interviewed, 7 fully sustained, 3 partially sustained, and 2 did not sustain. And one thing that we learned and rather new, but it's worth emphasizing here, that embedding services into ongoing systems is very useful and very effective. Prior to grant funding, five of these organizations, 5 of the 12, were implementing a variety of behavioral health services. And they continued to after the grant funding. An additional 3 organizations were implementing a traditional care management, and they were able to sustain an enhancement of depression care management as an additional component of their ongoing services. No one funding source is sufficient for sustaining services. The concept of braided funding is very important to fund one service with one stream of funding and another service with another, and pulling funding from physical health, mental health, and aging sources is a very effective strategy to continuing services. Not surprisingly, billable services were most frequently sustained. So traditional care management, depression care management, psychotherapy, and psychiatry. And the most common sources of funding following the grant period were Medicaid, Medicare, AOA, philanthropic, and other federal sources, which includes partnering with FQHCs and funding through HRSA funding, and partnering with the GEC and universities, which also provided HRSA funding. Other sources included CDC for continuation of the original RCT, and in one case, the USDA Community Food Project. And other sources include private insurance, SAMHSA, local government, and other resources. So besides the sustainability framework, the other major, what we consider product in the report is a primer on potential financing sources. So we heard from grantees that they really needed more information than a paragraph, but less information than the books and 100-page documents that are out there. So we have 2 to 4 page primers on each of these funding sources. So on traditional Medicare and Medicare Advantage, Medicaid, traditional state plan services and waivers, private pay and insurance, different types of SAMHSA block and demonstration funding, primers on administration on aging funding, and other federal, including partnering with FQHCs and giving the Aging Services Network more information about how FQHCs and HRSA funding works. In addition, there's information on state and local government and special taxes, philanthropic funding, and creative partnerships in social enterprise. So with that, I plan for this to be about a 30-minute presentation. So there's time for questions, if there are any, or I'll put up my contact information again, and yeah, we could follow up offline.